a pleasure to have you joining us for another Rush Generations lecture today on Wednesday, April 5th, 2023. My name is Kim Morley, and I'm the program coordinator for Rush Generations. And this lecture is being brought to you by the Social Work and Community Health Department at Rush University Medical Center in Chicago. Today's lecture is titled Back and Neck Pain. And for this lecture, we are delighted to have one of our esteemed Rush colleagues sharing her expertise on this topic. And first, to begin with, I want to thank Hannah Weitzman, who is providing technical support today and offering support behind the scenes. Thank you so much, Hannah, for all of your help. Also, if you want to watch previous Rush Generations lectures, get notifications of new lectures and videos, please click the subscribe button and turn on your notifications in YouTube so you don't miss any information. And thank you to those of you who are joining over the phone and on YouTube. For those listening on YouTube, if you have any questions for our speaker, please type them using the live chat button located in the bottom right side of your screen. And your questions will be answered at the end of the lecture. For those of you listening over the phone, there will be an opportunity at the end to unmute yourself to ask questions. And now for our presenter today. Dr. Dua is a board-certified physiatrist who received her medical degree from the George Washington University School of Medicine in Washington, D.C. She pursued an internal medicine preliminary internship at the Allegheny Health Network in Pittsburgh, Pennsylvania, and then completed residency training in physical medicine and rehabilitation at Temple University and Moss Rehab in Philadelphia, Pennsylvania. After residency, Dr. Dua returned to the Allegheny Health Network to complete an accredited interventional pain management fellowship. Dr. Dua was previously in private practice in Philadelphia and New Jersey, and she started at Rush in June of 2022 and is the main downtown campus physiatry lead of the Spine Center. She has extensive training in a variety of fluoroscopically guided interventional spine procedures, including epidural steroid injections, nerve blocks, radiofrequency ablations, and spinal cord stimulator trials to address acute and chronic back and neck pain. She also is skilled in peripheral joint and myofascial trigger point injections. Her goal is to integrate these interventional skills with her physical medicine and rehabilitation background to implement a multimodal, patient-centered, individualized approach to any pain issue. Thank you so much, Dr. Dua, for presenting to our Rush Generations and community members, and I will hand it over to you.
Hi there. Looking forward to talking with you all today, giving you a sense of some of the things I work with regarding low back pain as well as neck pain. A lot of those being actually, when I say relatively related, it's going to be nice because a lot of these concepts apply throughout the spine and will hopefully give you hope and answers. So I'm looking forward to this. So just to get going, let's talk about the agenda for the day. First, I'm going to give you an overview of back pain and neck pain in general. Some of the anatomy that I think is really important because when it comes to the spine, it's actually quite complex, but it is easy enough to break down to give people a sense of what's going on and how they can actually help themselves and what we can do to help them. But when we throw a lot of words around, people always say, I have, slip disc, bulging disc, I have arthritis. They may say a lot of things, but I think sometimes it's hard to know what we're talking about. So I think getting a little bit of anatomy is always helpful. And I think that we'll all know a little bit more about how to proceed and what to look out for in the future if we have a sense of some of the anatomy in our back. What are some of the main causes of low back pain and neck pain? That's important. Some simple terminology that gets thrown around a lot. I know people say things like sciatica and radiculopathy. Like, what do we actually mean by that? What are patients referring to? And sometimes I think it's misused, and sometimes I think it's totally appropriately used. And it's not about how it's used. It's more how that type of description helps the doctor give you better care. So kind of giving you some tools about how to explain your symptoms in a meaningful way so that people can give you the care you deserve and need. Also, we'll go over what imaging tests are done generally and if they're required or when they become required or needed for your care. Also, low back pain treatments, of course, that's important. And then when you really need to seek help, when is it time to see a physician to get things moving? And when is it that you can kind of just see if you can do things on your own, empowering you to do stuff at your house, etc. So just to start with the overview. Low back pain is actually extremely common. You can't tell me that you haven't had a friend or a colleague or someone that you've run into that hasn't had back pain if you haven't had back pain yourself, right? Neck pain as well. It's often related to stress and other factors, but I feel like it's just one of those really common things. And as we go forward, you'll see that actually greater than 80% will have actually one episode of back pain in their entire life. That's a really high percent. There are other diseases out there that are, of course, as prevalent, but an episode of back pain or neck pain is often something that affects people's lives and their well-being, and they don't always know what to do with it. So hopefully this talk gives you some of the ways to battle that. Most often, though, I'll be honest with you, it can resolve on its own. You may have had back pain or strained a muscle at some point while gardening or doing something out and about, sneezed the wrong way, felt the spasm in your back, and with maybe ice or heat and minimal intervention or just waiting, you may have noticed that it resolved. We say that these back pains can be categorized based off the amount of time. I don't always agree with it, but I'll explain what I mean. Acute, if someone's like, oh, the pain is acute, it means that it kind of just started within the past 4 weeks, and that's a little tricky because pain can change and it may start as a small thing and then disappear and then come back. So acute pain is really, we try to say new type of pain means acute. The second level is actually, I'm so sorry, that's a mistype. It's subacute, not subacute. That means lasting anywhere from 4 weeks to 12 weeks. And then the term chronic, this is my tricky one. Chronic is saying, and this is basically so we can have studies and, have a parameter. We say greater than 12 weeks, but I don't want you yourself to be freaking out that you are now a chronic pain patient or something because you've had back pain for 12 weeks or greater, okay? Because we say the word chronic, it means that we have to approach it a certain way as a physician. It does not mean that you are chronically going to have this issue and that it's not going to get better. It doesn't mean that it's time to lose hope. It means that we are labeling it because we have to do these things to better treat you in the future. So when we say it's been going on for a long time, we want to really get things moving if it's been over 12 weeks and you haven't yet gotten care, okay? Most episodes, like I said, can resolve on its own. But of course, some people do go on to have long-term pain, and our goal is to try to figure out where you are on that continuum and make sure that we give you the right care. Next slide. Keep in mind, it's the number 3 most common reason for primary care visits in the US is low back pain. Neck pain, I believe, is at number 5. Number 1 cause of disability under the age of 45. So people of all ages are battling this. We, of course, see a lot more back pain as people age. We actually see more of it. But that being said, of course, it goes to show you how prevalent it really is, even in younger people. It affects 80 to 85% of adults at some point, like I said, during their lives. So we're going to, at one point or another, you're going to see this potentially, and hopefully we give you some tools as to how to go on forward with your life in a way that's meaningful. Some risk factors just to keep in mind. Can't always control all of these things. For example, if you're born in the female sex, you can't control it, but we can control things like smoking. Obesity is a tough one. You got to always try to focus on your overall health. People always say you got to lose weight, and people will tell me I can't lose weight because I have pain. It's going to be a lifestyle situation where we have to work on a lot of factors. And a lot of times we talk about that in my clinic about, strategies to eat better, healthier, and other ways to approach obesity. Older age, like I just mentioned, can be a risk factor as well. Physically strenuous activity or even sedentary work, it seems opposite, right? Physically strenuous, meaning people that have to do a lot of lifting, and moving of things, sometimes sitting on a tractor that has a lot of, vibration, or sedentary work where you're actually sitting for too long a period of time to the point where you actually end up with other types of issues like weakness in the back and other type of pain. Stress, often job-related stress, but stress in general can exacerbate neck and back pain. Job dissatisfaction sounds random, but it's true. There is a correlation in many studies between being unhappy at work, having stress at work, and then having that transfer and translate into some low back or neck pain issues. And of course, sometimes anxiety and depression can be it's sort of sometimes a chicken or the egg issue, right? You don't know which one started what, but having the pain can lead to some anxiety or depression. And sometimes anxiety, depression can actually fuel some of the symptoms. So these are all things that are risk factors for low back pain. Next slide. Let's talk about some of the anatomy of the back, right? 4 main regions. So people will throw on things like my neck hurts, my mid back hurts, my low back hurts, and then the area around my buttocks, not sure if that's the spine, or my tailbone is really bothering me. We have fancy words for that, of course. We're doctors, we like to label things, and we have some fancy terminology. You may or may not have heard of the cervical spine, which is referring to the neck. It's when we refer to it, we're referring to all of the 7 bones that make up the neck. And we'll go into detail about what I mean by the 7 bones, but they're vertebrae. They're stacked on top of one another. People will label them C1 through C7, and then thoracic spine shows up. When we say C1 through C7, what are we even saying? I'll explain 1, 2, 3, 4, 5, 6, 7 is just that simple, from 1, and at the bottom is 7. And again, it is not just the bones that make up the neck. There's a lot involved in this, but that's just how we tend to describe these areas. The middle of the back, the mid-back region where the ribs come off, is called the thoracic spine. And there are thoracic vertebrae, and there's 12 of them. So it makes up a large portion of your spine in general. But there's a lot less movement of that area because it can't just collapse on each other the way the neck, you look up, you look down. There's a lot of movement. Same with the low back, a lot of movement when you bend at the waist. But the thoracic spine is a more stable part of the back because it holds the ribs, like I mentioned, and so it can't just collapse on each other. So it tends to be an area where people carry a lot of stress, but maybe less disc issues, etc. But it can, of course, occur. And then the lowest part of the back is the sacrum, and then the coccyx. The coccyx is the tailbone, and that whole section of the spine is actually fused together in one component. Next slide. So this is just a spine model. I mentioned to you the neck, starting from 1 all the way down to C7. I just wanted you to get a sense of the neck has those bones. You might see that there's red on the screen. The red is representing vessels. The blue in between is representing discs. Those discs have a hard outside and a soft jelly-like inside. And the idea is that they are buoyant and they allow for movement in the neck and in any other part of the back. And they're very, very important because they can be pain generators, but they also are the only reason why we can move, right? If we had bone on top of bone, we're not going anywhere. So the discs play a really strong role here. Like brake pads, so to speak. We talk about the joints that interconnect. They're called, some people call them Z joints. They're called facet joints or facet joints. You'll hear it a bunch of different ways. But the point is that that's where we find arthritis in those joints. We have nerves. The spinal cord is held in the middle, and exiting on the side is the spinal nerve roots that go into different parts of the body. We say the word innervate parts of the arms or legs, depending on what part we're referring to, being referencing the neck or the back. Muscles line the spine as well, and those can become affected and get pulled or strained. And then I mentioned something called the sacroiliac joints, because those are in the dimples in the low back, and they too can get irritated and can be a source of pain. I just had a quick question. Is there a way for me to show my spine model at this point, Kim?
Yeah, feel free to go ahead.
Okay, sorry. Thank you. I just wanted to use the spine model because I feel like 2D images are really tough on people. So I'm gonna, and for those of you that are on the phone, I apologize. This is just a quick way of just letting those that are on video see what's going on. This is the back. Okay, when you look at the back of someone's body, this is what you'd see. When you feel your spine and you feel your back, you feel what I refer to as prominences or bumps right in the back. And that is right here. When you look down the side, you might see these joints, okay? These are the joints that people refer to as facet joints, and they can become arthritic and cause an aching, dull, pressure-like back pain that we have many different ways of treating, but this is the joints. People are like, how do I have arthritis in my back? What does that even mean? We're referring to these joints that interconnect one level to the next. So each of these can become arthritic technically. We say they're like a knuckle joint. If you've ever had seen someone with arthritis of their knuckle, you might see that it gets really big. The idea here is that that can happen in the spine. When it happens out here, if it gets big, it doesn't really affect anything necessarily immediately. You can have pain in the joint, but it doesn't affect any nearby structures. But in the spine, when you have arthritis of these joints, it can actually start pinching off some of these nerves, which are the yellow guys. So we'll get into more detail on that later. See here, this is the actual spinal cord, which carries all your nerves. It's like a highway for the nerves and sends out all the signals from the brain to the other parts of the body. It's protected by these bones. That's why you have a spine. It's to protect this cord and to protect the nerves that are exiting out of here. When it comes, let me turn this around now. Okay, this is the buttocks region, and that's that tailbone that you can injure when you fall on your buttocks. Okay, I'm going to turn this forward now. This is where the abdomen is, okay, in front. These are the bones in the back. Sandwiched in between are these discs, okay? Like I said, these are the shock absorbers. They are having a hard outside and a jelly-like inside. So we often will say it's like a jelly donut, hard outside, soft inside. Sometimes that jelly can be compressed and actually exit the donut. It can just bulge. It can, what we call protrude, meaning partially come out, and it can even come all the way out and start smearing and affecting some of these nerves, which can cause pain. Sometimes, let's say for the low back, it can cause pain in the leg. In the neck, when that happens, it can cause pain in the arm. So everything is very seemingly complex, but all connected. We do have muscles that line the spine and some ligaments and tendons back here, but they're not on this model. Of course, you can pull a muscle, like I said, you can carry tension in a muscle, strain it, so to speak. You can also have some ligaments that get pulled with sports type injuries and things like that, or a motor vehicle accident. And those are the supporting structures of the spine. I wanted to show you all this because this is the base of the spine, and a lot of the issues that often occur using regarding these structures. Okay, we can go back to the PowerPoint. Thank you. Okay, wonderful. Where are we? Okay, great. We can go to the next slide. Thank you. So I kind of went through a little bit of this. Some of the causes of back pain and neck pain. Some non-specific, honestly, greater than 85% is not clearly caused by a specific disease or abnormality or a serious injury. A lot of the time people will tell me, I threw out my back. I couldn't move. I was laid out. I couldn't do anything. What do they mean by that? It's essentially, I think, referring to the sudden onset of pain after some sort of physical activity, or sometimes not after a physical activity, but often after even going down and lifting something off or moving something, carrying a heavy object, and then having all of a sudden onset of terrible back pain. That's throwing out your back. And I get it a lot when people are shoveling or bending. We haven't had as much shoveling this year in Chicago, but those types of activities can cause people to throw out their back. And what does that mean? It's usually a muscular issue, actually. It doesn't always mean it's a muscular issue. It could be that the disc took a hit. When I say that, it could mean that there could have been compressive forces that made the discs hurt or material come out of the discs, which could cause pain all the way down your leg, like I mentioned, or into your arm. But oftentimes it's a muscle type issue that we can treat relatively conservatively. It can be severe. It can cause terrible pain. When I say non-specific, and when I say that it's not necessarily involving a disc or a nerve, it does not mean that it does not hurt. And it means that we still should take it very seriously. It often can improve. When I say on its own within a few weeks, I usually mean initially we say apply ice if there's any inflammation. Heat is nice for muscular comfort. So when anyone tells me, what do I do first, ice or heat? I always say, number one, do what's best for you. Okay. But I often see in my practice that ice helps initially when the pain first comes on, because we're cooling off some of the inflammation that could be present initially. But as it sets in, the muscles start feeling sore and tight, and then heat can be used to help with some of the stretching. We tell people if you can avoid bed rest, we recommend that, because movement is actually a better treatment. When we see people in bed rest, the studies show that they actually do worse. Although some people have been what we call laid out, meaning they've been thrown out their back and they're unable to avoid bed rest. In those scenarios, we say, of course, wait and see. But if you have other symptoms, of course, seek care. But we'll go into that again a little bit more later, looking for what we should look out for that would require you to go into, let's say, an ER, for example. Next slide. Serious causes of low back pain exist: infection, tumor, something called cauda equina syndrome. That's why whenever you ever go to an emergency room, or if you ever speak to a doctor about your pain, they're going to ask you, do you have any bowel or bladder issues? What do they mean? Are you having issues with your feces? Are you having trouble going to the bathroom? Or more commonly, are you going to the bathroom and you didn't know that it happened? Okay. Are you able to hold on to your urine? I am not usually referring to just frequency of urination or urgency. I'm referring to having to just kind of wetting yourself, so to speak. And then you have usually back pain and leg weakness. And if you have a constellation of those symptoms, meaning if all those symptoms are present, we get a little concerned and say, let's see you right away and get a scan to make sure that you don't have pinching of the area where a lot of the nerves come together in the low back. So that's, again, cauda equina syndrome. Of course, we worry about compression fractures. For those that have osteoporosis or osteopenia, and like I said, it can be from something as small as a terrible sneeze or lifting an object, or it can be from a motor vehicle accident. There's many things that can cause a compression fracture. But it's due to weakening and thinning of the bones. Like I said, if you have a history of osteoporosis and you feel terrible pain that shows up in your back, and it can even be out of nowhere, we do recommend that you get that evaluated relatively quickly, just to make sure that you do or don't have a fracture. And if you do, making sure that it's stable or unstable. So those are serious causes of back pain that would require kind of more of a emergent evaluation, so to speak. Degenerative disc disease is the common wear and tear that can, we call it a disc disease. I hate the word disease. Is a hard word because it can be a natural process, right? As we're not 21 years old, as time passes, things take wear and tear. Discs are the same way. And they can look a little different than what they used to look like. They can dry out a little bit. So if someone gets a study and they read their MRI and it says disc desiccation, don't freak out. Desiccation means that some of the water has exited that area, but it doesn't in and of itself mean pain. You can develop small cracks and tears and lose some fluid from the disc, and that can lead to, of course, herniations of the material from the disc, which would lead to other sort of symptoms in the back and even in the legs. Or with regard to the neck, it can happen that you feel that in your neck and going down your arm. You can have formation of bone spurs. You're going to hear maybe doctors refer to things that you might have read on your scans or studies. Spondyloarthropathy, spondylolisthesis, all those, so many terrible terms, and they're very confusing. And then you start looking it up and wondering, what is an osteophyte complex? Am I going to be okay? Don't freak out. It's just, these are a lot of words and fancy things that we use to understand what's going on in your spine. And hopefully your physician will always go over what is going on. What are these bone spurs doing? What are they compressing or not compressing, and what symptoms are normal to have with that? Some being no symptoms at all, depending on where that's located. You can have changes in the disc that can cause back pain. And many older people with degenerative disc disease, like I said, can be completely what we refer to as asymptomatic, meaning no symptoms. So every time someone gets a scan, I always say, do not automatically just read the scan and say you have all the things on there, because it may not actually be something that you feel. It's more important to talk through what you experience on a day-to-day basis and determine which one of these things are actively part of the disease and what things it might just be there, but you're managing and dealing with it. We do say that core strengthening in general can be very helpful for this type of low back pain or neck pain. Core strengthening for the low back, and then some of the strengthening of the spine muscles in the neck can be helpful for this type of disc-related pain. So what is a bulging or herniated disc? You hear this term a lot. A lot of people say, I have, my disc is all messed up and the jelly came out of the donut, the doctor told me. What are they referring to? Bulging discs are seen on many imaging tests. When I say that, MRIs, CT scans, and many people tell me, I have bulging discs. You may have bulging discs. That does not always equal back pain. Bulging disc can be symptomatic, though, in certain scenarios. You could develop sciatic type symptoms that go down your leg, meaning pain that can feel lancinating, sharp shooting electric, etc. And that can go down your leg. And that is a sign of sciatic issue. If the bulge does press on a nerve, that is. Herniation of the disc is when that outer covering of the disc becomes so weak that material actually comes out. People worry about that. They tell me, oh my God, I have pain forever? The answer is often no. So again, not always the case. You can often get relief, and even though the material is not in the disc, it can still be a plan for recovery and less pain. Will the material grow back in the disc? As of now, we don't actually have a way of growing the disc again. That's lots of studies that try to make that happen. People have disc spacers and other types of procedures that they do, but as of now, there's not really the idea that the disc helps repair itself, but you can be asymptomatic, meaning no symptoms despite having that material come out. And there are exercises that can be done to help put the material closer to where it needs to go, meaning back towards the disc, making it healthier. People often call that a slip disc. And so again, that can lead to, the herniated disc can lead to leg pain or weakness. If it presses on the nerve root, it can also cause numbness, tingling type symptoms. There's something to differentiate there. When pain runs down the leg, there are positive signs and negative signs, but all of it is painful. But we say positive signs are those types of symptoms that have been added to your issue. So something like pain or weakness, those are things that can be pain, basically like, oh, it's shooting down my leg. This is a positive symptom, meaning it's not positive for you, but it shows something new that wasn't there. But if you tell me that you have numbness is a negative symptom, meaning that you're supposed to feel your foot, you're supposed to feel your hand. And if you don't, that can take longer to heal. So I always tell people the first thing that gets better is usually the sharp shooting electric pain, but some of that numbness and tingling can take a little bit longer to get better. Next slide. Just a little FYI, we do often treat those things with epidural steroid injections, meaning herniated discs with epidural steroid injections, sometimes anti-inflammatories, nerve medications, physical therapy. So we will go into all of that a little bit later. I don't want you to think I'm going to skip out on the treatment section, but I just want to let you know right now that just because these things show up doesn't mean we don't have options of how to go about treating it. And of course, if it needs a surgical evaluation, we do have a whole neurosurgical team here at Rush that sometimes has to remove that disc material. And that's called a microdiscectomy. We're not going to go into too much detail about that because I'm not a surgeon, but we do have options for those patients that have a terrible herniated disc and need an emergent evaluation. Next slide. So I mentioned arthritis, and I showed you on the spine model, the facet joints. So these are the interconnected joints. Each level is connected to the next through these. And just like a knee, just like a hip that can become arthritic, the back can also become arthritic. The issue is that, like I said, bone spurs and arthritis can actually lead to narrowing in the spine, which can lead to some of the symptoms of achy pain across the low back. But when it becomes very pronounced, when I say that, I'm saying when the arthritic joint becomes very large, that can actually graze the nerves and also cause some of the symptoms that could go down your leg or into your buttocks or into your groin, etc. So those are treated. I know if you've had knee injections in the past or hip injections or even shoulder injections for arthritis, what you may have noted is that you put some steroid in that joint and it can feel temporarily better. That similar type of procedure can be done for the back, but it's of course done very differently because it's not a joint that's what we call in the periphery, meaning outside of the spine. Just like in the knee, it can get big when it gets bad, just like a knuckle that gets arthritic, it can get big, it gets bad. That's the same thing you're going to see in your back. And so people always ask me, can you get rid of this arthritis? The only way to really delete it, so to speak, is by doing a surgical procedure that can help shave it down, but we can get rid of many of the associated symptoms that this can affect. So that's the important part. We can make your quality of life better with certain exercises, injections, medications, etc. A lot of people will tell me that with arthritis, similarly, when you take Tylenol arthritis, that can help with the low back. Arthritis type pain, as well as sometimes non-steroidal anti-inflammatories can even help with a little bit of an aching spine. So we have a lot of options. And I think it's important that we are open-minded about the different ways in which we can approach this. Later in the talk, I'll let you know that there is a more long-lasting option potentially that does not involve steroid, which is great. And it's called radiofrequency ablation. And it's for an option where we're actually able to get rid of some of the actual nerves that are causing the pain in your back. And that procedure can actually give you as low as 6 months we've seen, but as high as several years of pain relief regarding arthritis in your low back. So it's a great option and one that we would assess if you came into clinic with arthritis type pain. Spondylolisthesis, again, this is just another term that you're going to read on a study, and I just don't like people being scared of words. So what that means is when one level goes forward or backward in relation to the other level. And what that means is that it can cause compression of some of the nerves, and that's where we get worried. And the most important part is that when we send you off to go get x-rays, we might say, get flexion and extension films. What does that mean? We're having you bend forward and then lean backwards, and they're taking a picture of your spine. We're mostly wanting to make sure that you have a safe spine. And when I say a safe spine, we want to make sure that you don't need a fixation type surgery where one level gets linked to the next because there's instability. So spondylolisthesis has grades 1 through 4, meaning it doesn't always mean severe, and it's often written on studies. So it's the job of the doctor to really look at your study and let you know if there's anything, let's say exercise wise, you need to be careful of and make sure you avoid, or things that can help strengthen your spine to avoid that slippage from getting worse. Next. Spinal stenosis. I feel like this is a common one. A lot of people know spinal stenosis, right? You have stenosis. What does that even mean? So in Greek, it actually means choking. So what does that mean? The spinal choking, the spinal nerves, as well as the spinal canal can feel compression. So I think of it as it's like a house that's shrunk down, right? Because you're now having all the same things that are in your house, but everything is now in less of a space. So it's not that your nerves go and shrink away, but your nerves stay the same exact size, and yet the canal, meaning the bony canal, in fact, gets tighter. It can be from bone spurs, arthritis, bulging discs. Some people with spinal stenosis, though, will check them out in clinic. They really have very few symptoms. They're telling me that they are not truly very affected by this, despite it being on their imaging study. They're still able to get around. But more commonly, people will tell me that they have, pain and heaviness across their back. It can feel like a tired spine. Neurogenic claudication is a fancy word. Neurogenic meaning nerve, claudication meaning like heaviness. I'll explain. People will tell me I have pain that goes into my legs. It makes my legs feel like lead, like they're heavy, like there's pressure, or like there's just pain. And it usually involves both sides of the body when you have this. It can cause limping. Like I said, people will tell me that their legs get weak. Initially, it feels fine often, but as they continue to stand in one place or walk, they'll say it gets a lot worse. The pain is often also worse when they lean backwards and extend their spine. But they'll let me know that when they go to the grocery store, they'll grab a shopping cart and they'll start leaning on that cart to get farther distance and to have less pain in their back and in their leg. It's a very common symptom. We call it the shopping cart sign. It just means that you're getting relief by leaning forward. And why? Because there are holes in the back where the nerves exit. And when you lean forward, you're actually opening up those holes. So you're making the spine seem bigger than it is. People tell me that, when I shave my face in the morning or when I'm brushing my teeth over the sink, I feel terrible, discomfort if I try to stand upright. So I use my hand to give me support and I lean forward to give myself the ability to stand throughout that encounter. Or when I do dishes, I lean on the side. That's very common. And spinal stenosis is an extremely common diagnosis. There are interventional treatments that we do for that. At times, there are even exercises and physical therapy that can be done for it. Again, there's medications, plenty of ways to attack this, but oftentimes we would meet in person in clinic and kind of decide what the best route is for you. When it's too severe, and if you have certain symptoms and signs on your, physical examination, if it's too severe or out of control, there are times where obviously a surgery is considered. But that being said, generally speaking, we're able to get a lot of pain control with just simple things. Even modification of certain work environments can help, and giving you other options of how to treat this. So we can always get into that if you come into clinic, but spinal stenosis is a really common one, and a lot of people suffer from it. And oftentimes medications like gabapentin for nerve pain, epidurals, so meaning injections where we put medicine on the nerves to help kind of cool off the nerve, shrink them down, and help it fit in that tighter space. And then doing some exercising can help the low back and leg symptoms related to spinal stenosis. There we are. If you all are looking at the screen, you're going to see the shopping cart sign. I kind of went over all of this. Sitting often helps. Lying down can often help. By the way, if you're not classic and you have spinal stenosis and you tell me it hurts when I sit, that's okay. It's not. There may be other things. Oftentimes, this is a multifactorial, meaning many factors exist, and it often exists in the setting of having arthritis in the back, as well as bulging discs and other problems. So it's very common to have a mixed picture, but just classically speaking, it's pain that is worse with prolonged standing and walking and feels better when you lean forward or sit. I'm not going to go into too much detail. This is a good slide, but it's just a lot on it. It's a picture that lets you know that there's a lot that can happen. The yellow in the center is the spinal cord. On the sides is the exiting nerve root. On the left of the page, if you're looking at the screen, you'll see that this is what the bone should look like. This is what the nerve should look like. And this is what the disc should look like. On the right, you're going to see all the potential, what we call pathology, meaning problems. So you're able to see what I meant by the word osteophyte. What does that mean? A bone spur. That's sitting up at the front and can touch the nerves. When we talk about the herniated disc, you can see that material coming out of the disc on the right, and that can touch that nerve over there that's yellow, causing symptoms outside of the spine. So this is just a nice slide to just take a look at. So when if you ever were to need imaging and read some of this, it's a nice sort of thing to reference to better understand what might be going on. I mentioned two of these. This will be fast, just radiculopathy and sciatica, right? So related terms, radiculopathy is when a nerve root. What is radiculopathy? That's such a strange word. Radic is actually the Latin word for root. So when we say root, it means where the nerve is coming out of the spine on the side, okay? And something is pressing on it, which is causing usually radiating symptoms like numbness, tingling, potentially muscle weakness. And the idea here is that each of the nerves is kind of mostly responsible. I say mostly responsible for a reason, for parts of the leg, so to speak, or parts of the arm if it's coming from the neck. So pinching of a nerve is usually correlative, like I say, with one part of the leg. So if you have, for example, compression and squeezing of, let's say, the L4 nerve, that can often cause pain that goes down the front of the leg and into the shin and even to the middle of the foot or the big toe. If you have, let's say, compression of the L5 nerve, meaning one of the other ones, it can go down the side where you feel your hip is, down the side of the leg to the calf, and even to the top of the foot. So with the neck, we might say C7, it goes down the shoulder, back of the arm, and into the pinky finger. So these are really important for us to hear you tell us where are you feeling your symptoms, so that when we're trying to figure out what's bothering you, it helps us sort of look into it and know what to test on your exam, as well as what you likely have going on. Sciatica is a type of radiculopathy, and everyone likes to use that word because it's sort of generic. It just means back pain with leg pain. It can be any of the 5 nerve roots in the low back that can create sciatica. And it means that one of those branches are irritated. Again, you can get numbness and tingling, muscle leg weakness, and you can have just frank pain. So those are things to monitor. And of course, they can self-resolve, but when they don't, it's worth having an evaluation so that we can figure out what can be helpful for that. Coughing, sneezing, bowel movements when you're bearing down, those are things that can often irritate and cause more radiculopathy or sciatic symptoms. So just things to, again, look out for. Next slide. There we are. This is just showing you a picture of what that can look like, as it feels like burning, sharp shooting electric pain down your leg. So it's not that I need to show it to anyone that's had it. You know it. It's terrible, and it makes a lot of physicians uncomfortable, and it's often very treatable. So again, something to come in for if you have that pain shooting down your leg and it's not responding to things like non-steroidal anti-inflammatories like Advil or Aleve, if you're allowed to take those. Of course, some people aren't even allowed to take those medications. If it's not responding to exercise and time, then it's something worth getting us to evaluate. What imaging tests are ordered? So people will sometimes order x-rays. This is sometimes helpful, sometimes less. I'll explain. If you have pain shooting down your leg, we're not going to know why from an x-ray. You're not going to see disc information on an x-ray very often. Maybe a little bit, you'll see a bone spur, but you're not going to get as much. What you will have a sense of potentially is compression fracture. Sometimes you can see signs of cancer in bone. We can get a sense of the bone health. We can see if you have fusing of some of the joints, which could lead to other diagnoses. It usually doesn't give us as much as we want. So you'll often have people, when they have come in with acute pain, maybe get an x-ray to get things moving. But I'll be honest with you, sometimes it's just a requirement by insurances to make sure that we check that box off before we can order a higher level study. That is sometimes the case, but other times it can give us some meaningful information about the arthritis in your back, but not always. Again, oftentimes it means that if things progress and continue, we will have to order another study. Next slide. We might sometimes have to order a CT or an MRI. What's the difference? A CT scan comes with some radiation. Magnetic resonance imaging does not, so MRI does not. CT scans are very quick. MRIs take a long time. CT scans are really great, again, for bone, and we get a good sense of what that looks like, but it's much more detailed. An MRI is better for looking at ligaments, soft tissues, nerves, some of the more important structures. But that being said, not everyone can get an MRI. For those folks that have certain implanted devices and whatnot, we don't order MRIs and we just do the CT scan. And we can usually find enough information to at least make an educated decision of what to do next in your care. But again, this is recommended not for everyone. Usually, we hope that people have had, and some insurances require you to have had 4 to 6 weeks of physical therapy, as well as other, oral medications or whatever is deemed as conservative treatment prior to getting these images. And that's also because, like I mentioned to you earlier, a lot of times this pain in the neck or in the back can improve with time. So their hope is that they buy a little bit of time and give you a chance to get better on your own without having to get a study. I think it's important to get an MRI or a CT scan, of course, if we are concerned and you have a history of cancer or infection, or we suspect an infection and you're coming in with a fever or other type of symptoms. Surgery, of course, if it's being considered, we're going to need a higher level study. No one's going to do surgery on anyone that doesn't have this type of imaging. And even many procedures that I do require a higher level study. Not all of them, But many of my procedures, I would like to see what's going on at a more detailed level. If low back pain persists for more than 4 to 6 weeks, like I said, and we don't know why, it's really important that we figure it out so we can give you care. But again, if you just had it for a couple of weeks, a lot of times we won't jump into the CT or MRI because it may not be warranted, and it also may not be necessary. It could just get better on its own. And again, another thing to keep in mind, we get studies like this, MRIs and CT scans, but I always tell people, just because there's a finding on the study does not mean that you have a symptom. So the most important thing that happens with a doctor-patient interaction is you telling us what your symptoms are, how it feels for you, how it affects your quality of life. What is it making you not be able to do? What is it allowing you to, see that you're having trouble with certain things, right? It's important to listen to you, and that's a physician's job, and then make a decision as to what might be happening and let you know this part of your MRI is important, but just because you have a herniated disc over here, you don't have any symptoms, so we don't have to treat it. The important part is treating not the image, it's treating you as a person. That's the most important thing. So hearing your story, hearing your symptoms, examining you, coming up with a clear plan, and then looking at the imaging is the way that we determine what to do next. We don't treat MRIs, we don't treat CT scans, we treat people. So it's important that we have that interaction in person and have that evaluation to figure out what to do next. And I've had a lot of people come in and tell me, the surgeon saw me and I need to have epidural. And I examine them and it doesn't seem consistent, in my opinion, to be going forward with an epidural. I, in fact, find out that their pain is really in their buttocks and it's from an SI joint issue or or it's myofascial pain in their neck and it's not pain shooting down their arm. I should be doing something in the office, like a trigger point injection where I can help some of the muscle pain. So the reason why some folks get frustrated is that they want, an immediate injection, but again, the conversation that we have is valuable to me. And I often find that by having a talk and looking at your images together, we both come out with a better understanding of what's best for you. Next slide. So again, I've mentioned a lot of this throughout the talk, but I'll just keep it brief so you remember. Remaining active is important if you can, even if you pull your back out or throw it out. Severe pain could, of course, require some rest for a day or two, but prolonged bed rest is definitely not recommended. If you can't get out of bed for greater than 2 days, you need to be seen by a specialist or a physician or an ER, an urgent care. Someone needs to see you if you can't get out of bed. How does that happen? I've had people tell me that they need to call an ambulance. I don't want you to have to do that. I don't want it to ever get to that point, but I tell you, I don't want you, if you can't move for greater than 2 or 3 days, really, you're stuck in bed. We should be figuring out what we can do to at least get you more comfortable. Some people, I tell them it's good to lie on your back with a pillow under your knees when you pull out or throw out your back or you feel a lot of pain in your spine. That's because it offloads some of the stretching of your nerves. You may also find comfort in putting a pillow between your knees. So those are things, keeping your head or shoulders elevated. So I've had people tell me that they kind of sit in a chair for a day or two and sleep or a recliner. That's unfortunate, but can get them through that initial terrible pain. Again, movement helps to relieve muscle spasm. So that's something to keep in mind. And it also prevents loss of muscle strength. And that's important when it comes to the spine. You should avoid, of course, strenuous activities during acute pain when it's new. So telling people, you got to hold off for a moment till things cool down is very important. Light exercises like walking is usually okay as long as it's not causing a lot of pain. A lot of times we'll send our patients to physical therapy or they've already been to physical therapy. Because why? What does that mean? We're trying to get you to someone to evaluate your strength and your flexibility so we can basically give you options to improve on your own. They give you tools to really activate your own muscle groups and know what to do. Of course, sometimes they'll apply heat or ice or TENS units and sometimes even do things like massage or cupping. Different therapists do different things, but eventually they'll teach you exercises that can empower you to take care of some of your symptoms on your own. You could apply ice or heat initially. I mentioned my ice heat thing. Ice usually helps the first 24 hours. After that, whatever feels good to you, ice or heat. TENS units are also sometimes used by practitioners, and some people actually can get them on Amazon. They're just electrical stimulation, and it works by basically putting the pads on the low back or the neck. But again, keep in mind to read the directions and not put it on somewhere where you shouldn't. And it will come with instructions like that so you don't cause any issues. And again, don't put on a TENS unit if you have a defibrillator in or anything like that. You'd really want to consult your doctor before doing anything that could harm you. And that can send electrical impulses that can cause a vibration to go through your body and in that area, making it so that your brain does not perceive the pain as much. So it can give you some temporary relief. Massage or spinal manipulation can be appropriate for some folks, not all. Sometimes people ask me, they have a brace, they got a back brace from CVS or a friend or whatever it may be. I always say bracing has pros and cons. Initially, it's okay to sort of secure your spine and get rid of some of that initial pain at the beginning of a pain episode. However, bracing long-term actually can be really a negative feature, because what it does is it makes it so that your back muscles and your abdominal muscles, your core, so to speak, aren't working to keep your spine upright. And so by having a lot of tightening in the back, you can have that compression. It can feel good, but you're not giving your actual spine the chance to strengthen and, strengthen on its own and use its core. So I tell people initially it's fine to do something like holding it together, but long-term use of a brace will only eventually lead to weakness of the back. That, of course, does not apply, to compression fractures. When someone has a compression fracture with osteoporosis, that bracing needs to be led by a doctor that's monitoring and letting you know when you can discontinue using that brace. But in all other scenarios, I'm essentially referring to bracing for comfort is okay initially, but again, weaning off of it is important to maintain spine strength. Some folks have tried acupuncture. The studies are kind of hit or miss depending on if that helps you. That's person to person and individualized. Unfortunately, not always covered by insurance, but it can be a nice way to have relief without having anything like a medication going in your body. So some people really like it and swear by it. Next slide. Again, you may have heard of some of these medicines. Acetaminophen. What is that? Tylenol. Right? Tylenol is great. It really helps with arthritis type pain, aching in the low back, and can help in certain scenarios. Of course, if you have liver disease, I would mention to be aware of that and consult your primary care before you do anything by taking too much of that medication. I always tell people not to exceed 3 grams per day, which is 3,000 milligrams. Anticonvulsants. What am I even talking about? You've heard of some of them, maybe Lyrica, gabapentin, Topamax. What are these? These were initially created as anti-seizure medications. But what we found is that they often can work really well in the periphery. What do I mean by periphery? Again, we often find that it helps with nerve pain that's going on somewhere outside of the brain. So nerve pain in your leg, if you're experiencing numbness or tingling, or if you're experiencing sharp shooting electric pain, these medications can help calm them down, making it so that your spine is less likely to send out these hurtful, painful signals. So they can be very helpful for a lot of patients. Tricyclic antidepressants, you may have heard of amitriptyline or triptyline. If you have not, that's also okay. These are medicines that can lessen pain of damaged nerves as well. And for those folks that have depression or issues with those forms of mental health, you can actually see that this can be a helpful treatment of that for some of the mood symptoms. And they can also help people with sleep. So we often have people take that medication at night. It's not for everyone, and we'd have to look at the reasons why you have back pain to see if that's a good option for you. So SNRIs, there's a whole boatload of them. I'm not going to get into all of it, but Cymbalta is a pretty frequent, common one that people will be put on. Usually will start at 30 milligrams a day, and that will be often doubled to 60 milligrams daily. And it's been proven to help people that have nerve-related pain, and even in some cases fibromyalgia. So that's one that can be discussed with your physician or with a spine specialist or rheumatologist, etc. Corticosteroids are, again, oral versus injection. What are we talking about here? So steroids. When someone gives you what we call a burst, often they might give you a Medrol dose pack, or they might give you an injection if you were to happen to have showed up into an emergency room. And that can help relieve pain temporarily and sometimes even long-term. if you are lucky. So oral medicine that helps drive out inflammation. You can't live on these medications, or we really try to make sure that patients don't live on oral steroids because it has a lot of negative downstream effects eventually. But in an initial moment, it can really help drive down terrible inflammation. The issue is that you eat it, so you put it in your mouth and it breaks down, goes in your bloodstream, so it goes everywhere. So there are times where it does not necessarily all go to the right spot. And for that, when that's needed, we often will try an injection to really target the location of pain. But one thing to mention with steroids is that those folks, if you have diabetes, keep in mind that it does temporarily increase blood sugars. So that's something that we really want to keep people monitoring after even oral or injectable steroids. I'll go into some of the steroid injections a little bit far down the line, but muscle relaxers, you may have heard of Valium. You may have heard of cyclobenzaprine, also known as Flexeril, methocarbamol, also known as Robaxin. There are plenty of them. And their goal, tizanidine, very common one. Those medications are meant to reduce some of the muscle tension and spasm. They can often have the side effect of sleepiness and sedation. So we have people monitor for that. Opioids. What's the role of opioids? Again, do they have a role here? The answer to that is opioids tend to work a lot better in acute pain. So we see people after a surgery, they often will require some sort of opioid medication, and that can help with their symptoms. But it's not for everybody, and it needs to be discussed with your physician on a one-by-one, case-to-case basis. CBD, and other, often people are talking about marijuana these days. That can also be a discussion with your physician or your pain specialist, and can help for a lot of folks. Non-steroidal anti-inflammatories are Aleve and Advil, other medications you've taken that are over the counter potentially, and sometimes prescription, that can drive out inflammation that are not a steroid. And then topical medications like lidocaine, lidocaine patches, Salonpas patches, Aspercreme, Arnica. Those are things that people often use topically on the outside. Next slide. I apologize. I realize I'm taking a while. I'm really almost done. When to seek help. When you need something like potentially a spinal injection, like an epidural injection. What does that mean? People hate the word epidural. They think it automatically makes them think of childbirth and whatnot. I'll tell you, these are different. They are not meant to give you anesthetic that runs out and is in a catheter. This is instead a very different space. It's just called epidural. Epi means above, and dura is the coating on the nerves. So we're putting medicine on the coating of the nerves. The point of that is that if you come in, people say, oh, I don't want an epidural. I had a terrible experience when I gave childbirth. I know some of you men on here didn't have that experience, but in general, I just mentioned that it's not the same and worth having a discussion with your spine specialist or one of us. Facet injections or facet injections for the arthritic joints. The medial branch blocks are the way to see if the arthritis is the true cause of your pain, and we can often burn off those nerves with a higher level procedure called an ablation if needed. We can put medication into other joints like the SI joint or near the coccyx, near the tailbone, and then of course hip injections. So these are all different injections, not all necessarily spinal injections, but these are ones that often require us to go to the surgery center to give you care that's targeted and able to focus on what we need to do to help you get better. We do myofascial trigger points in the office where I find the areas that are most tender and I put medication in them and open up the muscle to try to relieve it from some of its tightness. It can lead to less headaches if you have those, and it's often very effective, especially for pain in your upper trapezius, meaning near your neck and in between your shoulders. If you have pain that people say is on the outside of their hip, they're having trouble lying on one side or the other at night, and they have terrible pain that feels like it can radiate down their legs sometimes, or also go into their back. We examine them, and sometimes they can benefit from an in-office injection called a bursa injection, because it's a sac that basically is protecting your hip and can often be a cause of pain. So I just mentioned that if you're having trouble sleeping on one side or another, it might be worth having an evaluation with one of us here. You really should see your doctor if you had a recent fall or injury to your back, if you have numbness or weakness in your legs, if you have problems with bladder or bowel control, like I mentioned earlier, if you have unexplained weight loss, that's concerning and needs to be evaluated. If you have a fever or feel sick in any other way, really, that could make you think you have an infection as well. If you have, if you take steroids every day, that can weaken the bone and can often lead to thoracic compression fractures or the like. So we have you come in if that's you. If you have diabetes or other medical problems that can weaken your immune system and the pain is not improving with time, we ask you to come in to be evaluated. If you have, again, cancer or osteoporosis, you want to get that imaging or potential imaging faster. So you'd want to come in. If you have new back pain that comes out of nowhere and you're greater than 70 years old, you may want to see a doctor or your nurse just to get a physical therapy prescription and also to see if you actually require a new image at that point. And also, if your back is so severe you can't actually do simple tasks, then you might want to actually just be seen by your primary care doctor to see if it's worth coming in to see one of us. And also, if your pain doesn't improve within 4 weeks, it's probably best to start seeking out care and an evaluation to see if there's something small or big that can be done to help you. So I apologize, that was a little way longer than I anticipated. I just had a lot I wanted to say and share with you all. But that being said, of course, if you have any questions, I would love to have you in my clinic. I'm here in the new beautiful building called the RAB, Rupschlager building. We are seeing patients on the 6th floor. I am part of the physical medicine and rehabilitation department. But I work amongst the neurosurgery department as well. So a really great way to get plugged into the system is by being seen by the spine center, where we're able to figure out what we can do for you and hopefully give you some relief if you do happen to have neck or back pain that's been ongoing or is not improving with simple, tactics like at-home physical therapy, exercises, ice, heat, oral medications that are from over the counter, etc. So we're a good option if you're continuing to have issues.
Thank you so much, Dr. Dua. That was an amazing presentation, and you provided such comprehensive information on our spine, the causes of back and neck pain, how to treat them. So yeah, I know I personally learned a ton of information, so thank you so much. And so now we want to transition to our question and answer time. For those folks who have called in to the Zoom meeting, you can unmute yourself to ask Dr. Dua a question by pressing *6.
Oh, Dr. Dua?
Oh,
Yes.
there we go.
This is a classic, great lecture, by the way. One of the best of all time.
Oh, thank you. I appreciate it.
You should be put in some sort of permanent record
Oh,
for the
that's very
government
sweet of
to study this. But anyway, when I was playing golf at 56, I finally learned how to hit the ball nicely and smooth, and then my back started. I saw Dr. Romeo for a frozen shoulder.
Okay.
I'm not sure what caused it, and I had physical therapy for years. It still doesn't help. Then he said 65% chance that the surgeon had it at Rush Orthopedic said it's a 65% chance of success to fix the disc. My question, I didn't do it, but is golf just not good for your back no matter what? Even if you have a trainer and you're a professional, you still get injuries.
I know it's terrible that you can get injuries. You can get injuries doing so many things. I actually think, honestly, golf is a wonderful sport. It does require a little bit of torque on your low back, as you know, as someone that's done it. So that
You're
twist
right.
can definitely be a moment, what we call it, in the spine. And so we often see folks that if you don't have a strong core, and I say core, I'm not just referring to, everyone thinks I'm talking about their belly all the time. Yes, of course, your abdomen is involved, but I'm also referring to the way, and you if you've done golf, you understand that it involves more than just your abdomen. That's not the part that we're talking about. It's the low back,
Right.
It's the abdomen, it's the quads, meaning the front, it's the front of your legs, it's the buttocks, it's
Right.
the hip. So all of that together, when it's strong, is completely safe. And when you're not strong, there are certain things that you can do to offload and offset and make sure that parts of it are stronger so that you can avoid injury. I have a lot of golfers that unfortunately end up in my clinic because they have
Right.
one small piece or another that we're able to get better.
Yeah.
But
Right.
it's not a dangerous sport, but there is elements of it that I think people do it without necessarily thinking that they have to do anything on their own, meaning I don't think they think they need a strong core to do it. And they actually would be better off if they did other exercises outside of golf that would
Oh,
make them better to do golf, right? Does that make sense?
are you like, yeah, does another disc tend to be injured later, a few years later,
So
if you
when it
have the
comes,
first one done?
so what did you get done? I'm sorry, I guess that's more of like did something specifically get done to a disc?
No, no, they just physical therapy, but it never really it helped, I don't think. Yeah, it's a 65% is not a great percentage success rate, is it? And then could it
No, so
damage another
I
disc?
wonder what they were actually referring to when they said 65%. Were they talking about of like a disc improving that was only 65%, or was
Yeah,
there a specific injury to that disc?
right, right. No, I don't know. 65% success of surgery. Does that mean
Okay.
another disc would go bad in a few weeks? And
Well,
because
so that
physical
was like a
therapy
case by
can
case.
affect something else.
Yeah, so the
Oh, okay.
interesting thing is it depends on if they were talking about doing a fixation surgery. They may have said that when we fixate your spine, it can affect the level above and below because that one segment isn't
Oh,
moving. So you're having more movement above
right,
and below. So it's very common, but reality,
right,
we can often get this under a lot of control. And I don't always just say physical therapy. It's often kind of reinitiating an evaluation. If you were doing that and enjoyed golf, I
okay,
always feel that people should try to do the things they enjoy and love, but getting you set up for that is really important. So being able to talk through your specific body and
right,
what we can do for you, also kind of focusing in on what parts of the spine are affected and how we can improve that with
right.
exercise or potential injection, and see if that's
And,
where we land with this.
but
And then deciding if you actually would only be a 65% success. I don't know what they were referring to. I think we see a lot of
yeah,
success, and it's also dependent on spine to spine. But my hope would be that we'd be able to identify what's wrong and then let you know if it's actually worthwhile to attack in a more aggressive or less aggressive way.
thank you. A frozen shoulder. What is that, by the way?
Frozen shoulder. So
I
that's when the capsule of the shoulder becomes sometimes so inflamed and tight. First, it starts as inflammation, and then there's no more inflammation. And it just is a capsule that gets tight. So there are sometimes orthopedic surgeons that will literally go in and open up and do a surgery to release said shoulder. We've had more folks often not get to that point, and they're able to use,
right.
stretching and whatnot to gain relief. And as we've found, certain injections into the shoulder can actually, the steroid helps reduce some of the inflammation of the sac that lives there. And so then by doing
Oh,
exercises, we're able to get more out of it. So I think it's important that frozen shoulder, yes, it gets stuck, but we see a lot of success with injections, but when we don't, there are times where a surgeon will get involved and actually open up, because you need to be able to access your armpit, for example, to apply,
yeah.
for hygiene and things like that. So how frozen also does make a difference. But
So
there
it's it's very complicated. There's a lot of pain involved in physical therapy, I think.
Yeah, there can be. And that's why sometimes we do an injection to reduce the inflammation so that you can actually be more successful in therapy.
Okay. Thank you very much.
Yep, no problem.
Acupressure, is that good? Shiatsu?
Oh, acupressure is actually great. I could have mentioned that. I just mentioned so many other things I didn't want to overwhelm, which I'm sure I already did. But
Right.
acupressure, what is acupressure? That's identifying those points. And what we found is that a lot of studies show us that acupressure points where people are finding the confluence, meaning their muscles come together like this, right? And so when you get a knot in your back, we want muscles to look, if you can see me, if you're not on video, you can see me, but if you're on phone, you want proper alignment, meaning you want them to look like straight lines. But what we'll often see is a tightening, like a knot, so to speak. And by pushing on them, you can actually release some of the fibers and it can become more normal. That's if it's not working with acupressure or acupuncture, there are times where we'll do trigger point injection, like I mentioned, where we actually put medication into that muscle and open it up to give it a chance to relieve itself and then reheal.
Okay. There's a lot more to it than meets the eye.
Oh yeah, I know. And even when I look at it, I'm always like, wow, this is the most fascinating part of the body. Everyone always asks me, why did you choose this? And I was like, because there's a few things. Anyone, if you live on this earth, you've had an element of pain. You've experienced pain in some way, shape, or form.
Right.
There's got to be options and ways to treat it. And so I've always been fascinated by the idea of giving people an option and plan and empowering them to be able to do things for themselves, and then giving them some options that I can offer them as well. So I find the spine specifically to be fascinating, but honestly, any pain that could be improved with simple things is important to give people quality of life back. I don't, people say, oh, do you save lives? And I say, no, I'm a doctor that focuses on quality of life, but that sometimes gives improvement when you have some quantity of it too. I don't necessarily extend the days of your life by giving you less pain, but hopefully the days that you have are with less pain and more enjoyable by having some quality, right? Quality is sometimes more than quantity. And it's what I focus on. It's what I think is important to get through your day to day.
Yeah, no, I would definitely agree with that. It's like, less distraction and everything when, you don't have to be bogged down by pain or discomfort. So, yeah.
And most people do. Most people think doctors, we save lives. We're focusing on, and when you come into the ER, right, you're going to be, if you come in with pain, if you've been to the emergency room, you're often put to the back of the line because there's someone unless it's chest pain. Okay. But otherwise you're going to get pushed to the back because they're going to tell you, usually won't quote unquote kill you. But what people don't understand is that, of course, you got to treat the people that are coming in with the acute potential things that are going to actually affect their quantity of life. But there's such an importance in quality of life, but we find that it's better treated in the outpatient setting. So I just want to bring that up. You will not get the care you deserve or want in an emergency room. And I am saying that as someone that loves ER doctors. My brother is an ER doctor. I have nothing bad to say about an ER, okay, other than it takes a long time to get through it. But I will tell you that you will not get the care you need or deserve necessarily there, because their job is not to give you a diagnosis or to treat all of your pain. The job of an emergency room physician is to determine sick or not sick. Do they need to be admitted to this hospital? Or do they not? They're not there to give you a diagnosis of how to, manage this. And they can sometimes give you something for acute pain, but their job is not to give you a long-term resolve, right? They're not trying to give you back your quality of life. They're making sure that if you have an issue with the quantity of your life, you're getting admitted. And if you're here, I'm going to try and get you safe and out, but safe, so that you can see your primary care physician or a specialist that has something to do with what you're experiencing. So if you want quality care, it's not that you're not going to get it in ER. You're going to get quality care, but if you want care that's tailored to you, you got to see someone in the outpatient setting, because it's just not going to happen in an emergency room, because their job is very specific. They want to do a great job of keeping you alive, and they do a good job of that, generally speaking. So I just try to tell people say, I went to the ER because it's been bothering me for, I've had people that go to the ER for pain that's been going on for years. And I say, well, then you should definitely not. The ER is not going to give you what you need. You got to come see your primary or see one of us, because we'll be able to help you better.
Yeah, that's a really helpful description. Thank you.
Yeah.
So we do have a few YouTube questions that came in. The first one is it possible what happens in the back can cause nerve pain in the back of the leg? The comment or the listener said it's not the front of the knee, just the back of the leg.
Yeah, I will be totally honest with you. It is fascinating. The spine is fascinating. Pain, you can have a spine issue and have no spine pain. Number one, totally weird, right? You could have pain that is terrible in your calf, numbness in your foot, terrible calf pain, sometimes ankle pain, just knee pain. You could have literally just a symptom in your elbow or your hand and no neck pain. It is bizarre, but it can be stemming from your spine. So that's why it's so important to really seek the evaluation, because the spine is fascinating and it works by, it doesn't always hold the pain in itself. It doesn't, what we call centralize. It doesn't always happen in where the problem begins. It can have what we call downstream effects. So it can affect outside of the spine. So you may only have burning in your arm. You say, doc, I don't have any neck pain. It's just in my arm. I don't have any back pain. It's just in my calf. It could be your spine. You can have spine pain from something being compressed in your spine. It can be in the spine. And you'll say, it hurts in my back and it hurts in the back of my knee, but it doesn't go to my foot, or it hurts just in my buttocks and in my back, but nowhere else. Is it a pinched nerve? Worth an evaluation, right? Because it could be the spine does not always. I've had folks tell me that they had an entire knee surgery because they had some arthritis. They have some arthritis, they go through some injections, they get a total knee replacement, they still have knee pain. We look at their spine and they have a pinched nerve squeezing L4 on the right. And then they had a knee replacement. And I do an injection and their knee pain goes away. And so we just, it's worth an evaluation, always worth kind of just always knowing that it's not always the spine's fault, but it always can be the spine's fault. So it's worth an evaluation. So that's a good question. Yes, you can definitely get back pain that's related to the pain in the back of your leg. You could also just have leg pain or just have back pain. And that's what's frustrating about it. You can't always blame the spine, but it's always worth figuring out if it's involved.
Yeah, thank you. That's really helpful. Another YouTube question is, will taking drugs such as meloxicam or tramadol for low back pain, leg pain, knee or ankle pain be harmful in the future?
So, tramadol is like a partial opioid, right? So the problem with that is that one, it can cause the side effects, right, of constipation, sometimes drowsiness, etc. Of course, that's one side of it, but also it may become less effective over time, right? You can build up a tolerance in your body, and so the tramadol it can initially feel like it's helping you get through your day and you're able to do more of your activities, but I'll explain to you how it works. Tramadol sits on an opioid receptor like this. And so if it's holding onto it, it can block the pain. But as if you've ever taken anything like that or any other opioid, you'll realize it's not a painkiller. It's not. It's a pain duller. It dulls it, right? It doesn't kill anything. It just dulls it. It's not usually a great long-term treatment because it doesn't actually fix the problem at all. It doesn't actually try to address some of, like, let's say, the nerve pain. It doesn't calm down the nerve. All it does is tell the opioid receptors to say, hey, stop sending as many pain signals. So it can definitely be temporarily effective. But the problem is a lot of times people will require more and more and more of this medication without getting the same amount of benefit, but they'll end up with some of the terrible side effects like constipation. So it can, long-term treatment wise, not usually be awesome, but some folks do swear by it, and it can, if it keeps you functional and you're someone that needs that, we'd have to see kind of your medical history to see if that's an appropriate, thing to be on. Meloxicam, not a great long-term medication. People will tell me they've been on it for 5 years, and I'm kind of like, whoa, okay, let's see why, or if that's great. Why? Because it can cause too much non-steroidal anti-inflammatories can cause a lot of issues. It can cause high blood pressure. It can cause other issues in the vasculature like bleeding, and especially in the gut, the GI tract. So people can have just abdominal pain, but it can also cause actual frank bleeding of your and cause a gastrointestinal bleed, which has, and some unfortunate folks, led to death. It can cause ulcers in the abdomen. It can do terrible things downstream, but some people have stomachs of steel. I don't know about them, but even then they could have other issues. So even if it doesn't really cause the stomach pain or whatever, it can eventually take a hit on your vessels. And so I always say, clue in, check in with your doctor, see if you should be on these medications long-term. They are great to reduce inflammation in an acute setting or even a subacute, meaning even up for the first 12 weeks. But after that, if you're still requiring them, we really got to see if there's a better choice for you. There may be other things that would help you more than just an oral anti-inflammatory at that point. But yes, temporarily, those are great helps. Long-term, probably not my favorite treatment plan for a long, long life.
Gotcha. Yeah. Thank you for that. Because right, it's true. It's like, how do we know what's okay to be using in the present, but then what are those long-term effects? So
absolutely, and they can help. But then the question is, what does that look like in 5 months from now?
Yeah, exactly. Well, our last YouTube comment that we'll be able to answer is, can having sciatica pain be because of being overweight?
So, very good question. I mentioned you some of the risk factors at the beginning. One of them is being overweight, and I'll explain to you how that works. So, any pressure that you put on the spine, so the spine is supposed to be like this, right? And so when you put pressure, this is where the abdomen is. I'm sorry if I didn't explain that. This is the buttocks area back here. So when you put pressure from the belly in the front, it puts pressure on these discs, okay? And so when you have that pressure on the disc, it makes them more likely to herniate, Okay, so also obesity and any excess fat means that you're probably not having the deepest, strongest core muscles. So that means that the structure that's meant to really help support this spine is often not as strong. That's not always the case, by the way. I've had some people that are suffering from obesity or even just being overweight, and they still do activate their core. They're able to do certain exercises. So it doesn't apply to everyone, but I'm saying that it's called a risk factor for a reason. And it's because it often can mean your core is somewhat weaker. It's harder to get those deeper muscles strong when there's excess fat in front. It also puts a lot of forward pressure on the spine, which is onto these discs. So they have a higher chance of too much pressure can push the material out and onto the nerves. When it hits any of these lower nerves down here, it can shoot into the leg, or it can just cause other pain in the leg, which is what we commonly call sciatica. Okay.
Awesome. Thank you so much. Well, yeah, thank you again, Dr. Dua. This has been a wonderful talk on back and neck pain and just, structure of our spine and body. So really appreciate it. And for those comments that we weren't able to get to, we will still try and answer those at a later time. So the next part of the lecture is just wrapping up with talking about our Rush Generations programs that are currently going or that are upcoming. So Dr. Dua, you're welcome to stay on to hear more about that, but if you have to get on with your afternoon, we totally understand.
I'm going to actually go see some patients that are scheduled, but I appreciate everyone for coming and listening. I do hope to, if at any point you need to see me, I'm available. Again, very searchable now, especially because you have access to my information here, but happy to treat all sorts of issues. Would love to see you in clinic if you have an issue, but I hope that you don't have back pain and you were just here to get educated. Okay. But if you do have any back or neck pain, anything in the spine, just like I said, the best treatment you're going to find is by seeing someone that's willing to hear you out and give you a plan. And that's not going to happen necessarily in an urgent care or an ER, but for acute, terrible pain or something like we mentioned earlier, go to the ER, do what you need to do. But otherwise, be sure to come and see us, and hopefully we can give you some help and a plan of care. Okay. Take care. Thanks so much.
All right. So we will start with, I apologize. Let me get the slides lined up. So let's talk about our upcoming programs in Rush Generations. The first is our Tai Chi for arthritis and fall prevention. We would love to have you come join us in the comforts of your home, actually, for a virtual program. This is a 16-session exercise program focusing on relieving pain, reducing stress, improving quality of life. The results of participation in this course actually show up to a 70% decrease in the occurrence of falls, improved balance, significant pain relief, and less stiffness, as well as a better ability to manage daily living. So this class will be every Wednesday and Friday, starting April 19th and running through June 9th from 11 a.m. to 12 p.m. Space is limited and registration is required, so please call our 800 number to get more information or to register. Next is our Embracing Aging classing. This class is designed to improve muscle strength, range of movement, balance, and activities of daily living. A chair can be used for seated exercises or standing support, and exercises can always be modified to whatever your current abilities are. This class has already started, but you still have time to join. The final day to register is next Monday, April 10th, and this is hosted via Zoom from 1 p.m. to 2 p.m. There is a fee for this class, but we offer either partial or full scholarships. So please call our 800 number and we can give you more information about that, as well as get you registered. Next is our Health Legacy program for women. This is a free 6-week workshop designed for women of color wanting to make lifestyle changes for themselves and their families by eating right, losing weight, and improving their overall health and wellness. So join us for fun exercise, nutrition guidance, and health education in a supportive environment. And our next session will be held virtually via Zoom on Tuesdays and Thursdays, starting April 13th and running through May 25th. And it will be from 4 to 6 p.m. In the afternoon. And registration is required, so please call our 800 number to get more information or to register. And we will also be excited to offer our Health Legacy program for in Spanish for women. And so this is the exact same design of the class, just for people who are Spanish speaking, and it will occur during the same time frame. So Tuesdays and Thursdays, April 13th through 25th, through May 25th. So if yourself or anyone you know would be interested, please feel free to reach out. We also have our gentle chair yoga program going on, and everyone is welcome to this, whether you're new to yoga or you've practiced in the past. These poses can also be modified for sitting or standing, and this class has already started, but you still have time to join us. The last day to register is actually tomorrow, April 6th. So if you're still interested, we would love to get you set up for the remaining sessions. There are partial and full scholarships as well. So give us a call and we can try and get you set up. Next is our Walk with Ease walking program, which is offered through the Arthritis Foundation. Participants will meet 3 times a week at the Garfield Park Conservatory for a certified Walk with Ease facilitator, and then everyone will walk together. These walks will be at your own pace and can range anywhere from 10 minutes to 45 minutes. Any individuals who have either arthritis, osteoporosis, chronic pain, or other conditions are encouraged to participate. However, you don't need a health condition to join. If you just want to try and connect with others or become more active, you are more than welcome. So this next program will take place starting April 12th and running through May 19th from 1 p.m. to 2:30 p.m. And registration is required, so please give our 800 number a call. Next is the Take Charge of Your Health program, which will be offered in Spanish. This will take place on Tuesdays starting April 11th and running through May 23rd from 10:30 a.m. to 1 p.m. And a little bit more information about this program is that it's a self-management workshop designed for adults with 1 or more chronic medical conditions. You'll be able to learn how to build skills and gain confidence in managing your health and leading a more active and fulfilling life. And we continue to offer our friends and family of people with memory loss support group. This still meets on the 2nd Monday of every month. Our next group will be this upcoming Monday, April 10th, from 6 to 7:30 p.m. by telephone. For more information, please reach out to our group leader, who is Janine Quinn, and her phone number is 312-563-0650. And in addition, we continue to offer our diabetes education and support group, and this still takes place every 3rd Thursday of the month from 2 to 3 p.m. And our next session will be Thursday, April 20th by a Zoom conference call. And our 800 number is the best way to get more information or to register. Our Senior Friendly Connections, or I'm sorry, our Senior Connections Friendly Caller program is still interested in getting you connected with one of our trained volunteers for weekly calls. And these are designed to just be a call that can be on any topic that you would like. The calls can be as short or up to an hour. So if you would like to have one of our volunteers here at Rush reach out to you, we would love to get you connected. And our 800 number is the best way to get a hold of us for getting set up with that program. The Rush Caring for Caregivers program is an education and support program for family caregivers of adults 60 and older. You will work with professionals to figure out how you can help yourself in taking care of an older adult and get personalized education and support, build an effective team to help support you, and create plans that work for everyone involved. The phone number to get more information is 312-563-0350. And we also continue to have our Rush Older Adult Home Modification Program. And this is designed for folks who are 62 and over and living on the west side of Chicago to work with a team that can help them continue living at home safely. And so to get more information or to hear if you qualify for that program, please call 312-942-6400. And lastly is our Shulman Senior Voices program. Shulman Senior Voices aims to empower older adults to discuss what matters most to them as they age. And so we would love to hear from you and have you share your voice. Please consider recording a video, and you can do so by scanning the QR code that is on the screen with your smartphone, or entering the web address that is located on this slide as well, and you'll be prompted to record a video that way. You could also share reflections on what you learned from today's lecture, just sharing what is important to you. And our next lecture will take place a week from today on Wednesday, April 12th, and we'll be covering colorectal cancer and screening then. And this is our 800 number to call, 800-757-0202. And that's the best way to get more information on the programs or to register for the ones that we just discussed. And as a final disclaimer, we just want to let everyone know that the lecture today is not intended to be a substitute for professional medical advice, diagnosis, or treatment. We always recommend to seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Please never disregard professional medical advice or delay in seeking treatment because of something that you have read or seen on the YouTube channel. And if you have any questions that come up after this lecture, please don't hesitate to reach out to your primary care doctor. Well, thank you so much for your time and attention today. It's been wonderful having everyone, and